Hello, everyone. Welcome back to this year's CR Arthritis event at the I'm Kelly Lenvoy, VP of Communications and Public Affairs at ACE. And today it's my pleasure to be speaking with Dr. Derin Karacabeyli. He's a rheumatology resident at the University of British Columbia. And under the supervision of UBC and Arthritis Research Canada scientists, he's studying the effects of treating metabolic comorbidities like obesity and type 2 diabetes on patients with immune-mediated inflammatory disease. Dr. Karacabeyli, welcome.
Thank you so much.
Now you have the distinction of presenting a podium presentation in Winnipeg, and I thought we would take a look at that, and maybe you can just introduce the topic, and I can just ask a few questions to help our audience understand the significance of your study.
Of course, sounds good. So probably in the last decade or so, maybe even a bit longer, the treatment of diabetes has really evolved. And part of that is because there are these new classes of drugs that have become increasingly popular. So one of these classes of drugs, referred to as the GLP-1 receptor agonists, has gained popularity. And the other one that's gained popularity are the SGLT2 inhibitors. So these are two kind of drug classes that, especially in the last 5 years or so, have really become more and more used. And that's because beyond just controlling blood sugars in diabetes, these classes have also been shown to reduce the risk of death. They've been shown to help with heart disease, like heart failure, reducing risks of heart attacks and strokes. They've been shown to reduce the risk of having progressive kidney disease. And especially with GLP-1 receptor agonists, they've been shown to help with weight loss, which is one of the reasons why even outside of diabetes, they've become quite popular. And there was actually even a shortage, this past year. In light of their, oh, go ahead.
So just sorry for our audience, in case they don't understand what we're talking about when we mention GLP-1, we're talking about Ozempic, Mounjaro, those medications that are capturing a lot of headlines right now, and I think people will understand now what you're specifically referring to.
Yeah, exactly. Yeah, Ozempic or semaglutide, and then Mounjaro is tirzepatide. You're exactly right. Those are the ones that I'm referring to. And then the SGLT2 inhibitors, the big one is probably Jardiance, is the empagliflozin, or Forxiga, which is dapagliflozin. So those are the brand names. So again, those ones are also pretty popular, especially in the cardiology and nephrology, so heart and kidney worlds. But yeah, Ozempic and Mounjaro, they've become quite popular in the news of late, for sure. And so because of that, because of their increased use, one of the questions that we had was whether or not that has had any sort of impact in the past several years on the risk of developing an autoimmune rheumatic disease like rheumatoid arthritis, psoriatic disease, ankylosing spondylitis, etc. And really, we didn't have a directionality. We weren't sure if it would stay the same, if it would get better, or if it would get worse. When you look into the science behind this, what you see is there's really not a lot of data yet, probably because these medications are pretty new. On the basic science level, like when people do experiments, they actually do see that these drug classes might have beneficial immune modulating effects, like they might actually help with decreasing inflammation. But how that translates to patients clinically has yet to fully been teased out. And when it comes to actually incidence or developing new diseases, there's very little data. There's a couple of case reports where people developed arthritis after GLP-1 exposure. But again, that's only a couple case reports, and this has been used so much, so I wouldn't put too much weight into that. And there was one kind of larger study in psoriasis that found that after exposure to SGLT2 inhibitors, there was no difference overall, but in certain groups like those with kidney disease or those who were older, a bit of an increased risk. But again, it was just one study in a specific population, and the overall conclusion was still no difference. So because of such a paucity of data, we thought it would be interesting to look at this question.
So what did you find out?
Yeah, yeah, a lot of background, but essentially the bottom line is that there was no difference. So we found that if you got a medication, if you got a GLP-1 receptor agonist like semaglutide, or if you got an SGLT2 inhibitor like empagliflozin, compared to we had a kind of a third comparator medication that we used as a baseline, which hasn't been shown to increase risk. Compared to that one, no difference. The caveat is that our average follow-up was only about, it was between a year and a year and a half. So that's pretty short.
Hmm.
What that does tell us though is, oftentimes when we look at whether a drug is going to flare or cause a disease, we often see that sometimes we see that a bit earlier on. So I think sometimes within the first year and a half is not unreasonable to look for like a trigger. But to actually look at benefit, like are these reducing risk, we probably need longer term data.
And the longer term would be,
Hard to say, but like probably like 5, 10 years of follow-up would probably be more helpful.
so so early days, as you said, we're looking at this from a basic science perspective, translating into the clinical setting, um, and a time period where there is a level of uncertainty. What does this mean for patients? What does this mean potentially in terms of the conversations they might be having with their rheumatologist or other members of their healthcare team? Where was this going?
So I would say that based on our data, and we had nearly we had about 186,000 patients who were followed, who were like included in our population-based study, so it's
Hmm.
big.
Hmm.
So based on no signal, I would say there's no concern at this stage. So like I wouldn't be worried about a new autoimmune disease forming in somebody exposed to these drugs. Like I think that's not a worry. Um, so I'd probably leave it at that for now. Um, I'd be curious to see how, like one of my research interests is to see how these drugs might be able to benefit people with autoimmune rheumatic diseases and say obesity as well, and diabetes. Like if you have RA and obesity, if you get a medication like semaglutide, which helps you lose weight, will that also help reduce the inflammation that's driving your RA? That's kind of a question I have in my mind as well.
Yeah.
Um, the other thing is like these medications have been shown to, like I said, reduce the risk of like heart attacks, for example, in patients with RA. And those patients are already, sorry, they've been shown to reduce the risk of heart attacks in the general population with
Yeah.
diabetes, for example.
Yeah.
But whether they also reduce the risk of heart attacks if you've got diabetes and RA and how that compares to the general population, that's a study that we did and actually we presented at EULAR last year, and we're just trying to we're submitting it for publication now, but hopefully that gets published soon and we can share that result as well. But it looks like these drugs do also carry similar benefit in subpopulations with autoimmune disease, similar to what we see in the general population.
Yeah. So, you know, when our audience is listening or reading about the new class of medications and words like transformative and revolutionary, maybe not that far off the mark, because what you're talking about is when we have a breakthrough in the treatment of obesity, which, as our audience knows, sort of keeps the wheels of the chronic disease bus going round and round. I mean, it's really sort of the underlying factor with all these comorbidities that some of our patients living with inflammatory arthritis might have. This is a game-changing moment, and moving from no risk to possible benefit. We're going to be keeping a close tab on you and the research that you're doing, and obviously research that's being conducted around the world. It's a pretty incredible moment. So we're happy to hear that arthritis is taking this as seriously as they should, and people like you helping lead the way. So keep up the good work. It'll be interesting to see the reception that you get in Winnipeg. I think a lot of people, even at this high level amongst clinicians and researchers, probably have a lot of questions as well. And as we get answers, it's going to hopefully trickle down and benefit the patients. Anything else that you'd like to add before we finish?
No, I just wanted to thank you again for the opportunity to speak about my project. I think what's important to highlight is it is still, I think, important to acknowledge that these are very early days, and
Yes.
we don't know if these medications will be of benefit for patients with inflammatory diseases. I mean, we do know that they seem to be of benefit in the general population, so we would assume that they would hopefully be of benefit, but we're still testing those things. So I think it's important to be hopeful, but also realistic as well.
Well, as I said, we're looking forward to having you back with an update sometime soon on one of our East channels. So thank you very much for joining us today. It's a real pleasure meeting you.
Of course. Thank you so much.
And thanks to our audience for joining us again on another show from the annual meeting in Winnipeg. And we look forward to seeing you again very soon. Bye-bye.